Fine. So this is a really wonderful summary. I didn't expect you're going to go into the three phases of wound healing, but this is great. And let's just say the scar does not turn out to be ideal, right? And what can you do to correct it? I mean, first of all, there's different types. There's a hypertrophic scar, there's keloid, there's pigmentation. Maybe we can walk through the different scenarios and can walk us and talk about what treatment options that you have.
Well, there's always hope. And I like to quote my mentor, who's still alive, 92 years old, Dr. Perry Robbins, very wise man. One of the pearls I picked up from him when I was a fellow, things, first of all, do have a way of resolving themselves. But his famous line was sometimes you have to do the least in the most amount of time, because I think that tincture of time is a really important thing. With that said, people have to live their lives and people are worried and they don't really want to hear that it's going to be okay in a year. They want to know what can they do now or how can we kind of make things better. So I do think you have to separate out, you know, there's a subgroup of population and we know that maybe it's a little bit more in people of color, certain ethnic groups that are prone to keloids. Sure. And usually you're a keloid former. You usually know that by a certain age. Maybe you've had your ears pierced and you've gotten lumps from that. Maybe you've had your appendix out or you've had some kind of elective surgery or a trauma and you've developed a scar that's kind of out of control, growing way more than a normal scar. And a good surgeon is going to ask you usually before you have your melanoma removed, do you have a tendency to keloids? Do you have a problem with scarring? And if you do, you need to speak up, because if we anticipate that, we still have to take the melanoma out, but we'll be that much ahead of what we can plan for and what we can do. And if you do have that problem with keloids, there is help even for that, because sometimes, as you know, we can inject a cortisone, a steroid, into the actual keloid. Sometimes we can use liquid nitrogen, very, very cold, applied to the scar. There are methods. Sometimes, I mean, in a person, if it's a devastating keloid, we might even use a little low dose radiation. But there are ways to get keloids to calm down and not be inflamed and itchy or painful. And it would not be a reason not to take a melanoma out surgically because you had the keloid tendency. We just have to know about it. There are other instances where you don't have a keloid tendency, but maybe you develop a raised scar, and maybe the raised scar really is bothering you cosmetically, particularly if it's on your face, or maybe in the case of some women on the chest, on this area, the décolletage. So we do have methods. Early on, we often recommend that patients, first of all, use sunscreen over their scar, because that's going to be very helpful. Number two, we might have them topically apply something with silicone. It can either be a gel or it can be a kind of a patch, an occlusive patch. And we know that by keeping that patch on or applying the gel, there's something about the moisture in that patch against the skin that can help make the scar less red and less raised and calm it down. So we often do that. Sometimes we will inject the steroid into the scar in the office, and that is helpful too at calming things down. So we definitely have ways to modulate the scar. We sometimes use lasers on scars if the scar is too red because there's too much blood in the area and it's very inflamed. There's a group of lasers that only see red, such as the pulse dye laser, which can be employed to help the scar. If the scar is too dark and it's really looking very brown compared to the surrounding skin, we might use a different group of lasers, like the Q-switched pigment specific lasers. So we do have a lot of things in the toolbox. You know, even lately, there have been articles on actually botulinum toxin, which most people have heard of, like Botox or something like that, being injected into scars that can help flatten down the scars and make them less inflamed. So we have a lot of tools in the toolbox as dermatologists to help deal with scars. And in the planning, that's very important too. My husband and I, as we work together as a team, you might want to, if the melanoma is right on the nose, we might want to look, how does the light hit the nose? And before we go taking a skin graft and just making it a circle on someone's nose, maybe you have to change the shape a little bit into a parallelogram or a rectangle of sorts, because it's going to look better. Or maybe the melanoma is on the side of the face, and rather than just stitch it in the middle, if it's an older person, maybe a little bit of a facelift, a little bit of a nip tuck, and trying to put the suture line where the ear meets the face is going to not only take out the mandatory margin of normal skin around the melanoma, but aesthetically and cosmetically, it'll make the patient happier because they're going to look better. So there's a lot of finesse that goes into which way we should orient the scar, what we should do in terms of suturing. We don't want to put those old-fashioned sutures over the skin. If we can help it, we'll bury everything and do what we call a little running subcuticular. We take cosmetic into concern, even with cancer, because it's important.
Yeah, it's very important. I mean, I think that most melanoma survivors sort of see this, right, and have this kind of emotional stress associated with seeing this. So I want to ask you, what does your patient do? Now you got one side of the face that looks 10 years younger. Now they have to wait to grow another skin cancer on the other side. I want to ask you that.